Locked-in syndrome is a condition in which a patient is aware but cannot move or communicate verbally due to complete paralysis of nearly all voluntary muscles in the body except for the eyes. Total locked-in syndrome is a version of locked-in syndrome wherein the eyes are paralyzed, as well. Plum and Jerome Posner coined the term for this disorder in 1966. Locked-in syndrome is also known as cerebromedullospinal disconnection, de-efferented state, pseudocoma, and ventral pontine syndrome. Presentation: locked-in syndrome usually results in quadriplegia and the inability to speak in otherwise cognitively intact individuals. Those with locked-in syndrome may be able to communicate with others through coded messages by blinking or moving their eyes, which are often not affected by the paralysis. The symptoms are similar to those of sleep paralysis. Patients who have locked-in syndrome are conscious and aware, with no loss of cognitive function. They can sometimes retain proprioception and sensation throughout their bodies. Some patients may have the ability to move certain facial muscles, and most often some or all of the extraocular eye muscles. Individuals with the syndrome lack coordination between breathing and voice. This restricts them from producing voluntary sounds, though the vocal cords are not paralyzed. Causes: unlike persistent vegetative state, in which the upper portions of the brain are damaged and the lower portions are spared, locked-in syndrome is caused by damage to specific portions of the lower brain and brainstem, with no damage to the upper brain. Possible causes of locked-in syndrome include amyotrophic lateral sclerosis, diseases of the circulatory system, medication overdose, multiple sclerosis, damage to nerve cells, particularly destruction of the myelin sheath, caused by disease, a stroke or brain hemorrhage, usually of the basilar artery, traumatic brain injury. Treatment: neither a standard treatment nor a cure is available. Stimulation of muscle reflexes with electrodes has been known to help patients regain some muscle function. Other courses of treatment are often symptomatic. Assistive computer interface technologies, such as DASHA, combined with eye tracking, may be used to help patients communicate. New direct brain interface mechanisms may provide future remedies. One effort in 2002 allowed a fully locked-in patient to answer yes or no questions. Some scientists have reported that they have developed a technique that allows locked-in patients to communicate via sniffing. Prognosis: extremely rarely does any significant motor function return. The majority of locked-in syndrome patients do not regain motor control, but devices are available to help patients communicate. Within the first 4 months after its onset, 90% of those with this condition die. However, some people with the condition continue to live much longer, while in exceptional cases, like that of Kerry Pink and Kate Allott, a full spontaneous recovery may be achieved. Mimicking conditions: Cura poisoning mimics a total locked-in syndrome by causing paralysis of all voluntarily controlled skeletal muscles. The respiratory muscles are also paralyzed, but the victim can be kept alive by artificial respiration, such as mouth-to-mouth resuscitation. In a study of 27 Army volunteers who were paralyzed with Cura, artificial respiration managed to keep an oxygen saturation of always above 85%, a level at which there is no evidence of altered state of consciousness. Spontaneous breathing is resumed after the end of the duration of action of Cura, which is generally between 30 minutes and 8 hours, depending on the variant of the toxin and dosage. See also, akinetic mutism, brain death, amyotrophic lateral sclerosis. In final stage, notable cases of locked-in syndrome, vegetative state, references. External links: The Unlock Project, Locked-in Syndrome Association's Guide to Communicating Without Language, Rachel's Communication Boards for when you need to communicate with someone with LIS.